Victoria City Expats Club is a non-profit social organisation and our speakers are volunteers. The club as such assumes no responsibility or liability for the professional reputation of or the quality of services provided by the speaker today.
Noon, so as soon as the doctor's finished the talk here, he'll be available to do more checkups, etc. So it is World Stroke Day. I do emphasize it's a non-participatory event, okay? You don't have to participate, all right? Just register and learn. And of course it is, a very big problem worldwide. And we're very blessed to have Dr. Nattakon here from Bangkok Pattaya Hospital. The doctors take talks here really seriously. You go into their office, you'll see the plaque up that we give them, and that we've just had so many wonderful talks from them. We do miss Tanya, who's on holidays. She's an institution here from Bangkok Pattaya Hospital. So I'm not going to sing all the praises. I think who had a session with Dr. Nattakon at the MRI machine and stuff? And you're still with us. It's amazing. All right. So please, Doctor, come up and enlighten us on World Stroke Day. Yeah, big round of applause.
Sawadee krap. Good morning, every people.
You need to hold it like here.
Oh, thank you. First, in Stroke Day, I wish everyone free from stroke. But today we talk about when stroke strike. It's just sharing, not too serious. Stroke is a serious situation, serious disease and serious situation. Stroke has a leading cause, the second leading cause of death and disability worldwide. But in Thailand, stroke is number one. The number one leading cause of death in Thailand. And now you stay in Thailand. What is stroke? Stroke is a brain insult. It's something that happens into your brain suddenly. Major is caused from the occlusion of your artery that supply your brain, or it's burst. Okay, that can cause the disability leading to death in some case. The type of stroke, closely we can make the type of stroke into the bleeding stroke that we name the hemorrhagic stroke, or the occlusion stroke, or the ischemic stroke. And the ischemic stroke consists of the artery itself closed by the plaque we call atherosclerosis mechanism, or the thrombus fly from the outer organ, especially your heart. That's why in patients who had heart irregular, that's the risk of stroke, especially atrial fibrillation. In patients who had atrial fibrillation, doctor give you the anticoagulation or blood thinner. That's mandatory. You need it. Oh, sorry. Okay. The ischemic, that means something occlude to the artery that supplies some area of the brain. The symptom of the patient is very big different. That depends on what area of the brain affect. It's the same symptom, both ischemic or hemorrhagic stroke, but in case of hemorrhagic stroke, is much more chance to have a serious headache. Basically, in ischemic stroke, the patient rarely to be headache. The burden of stroke, as you know, nobody would like to be a stroke because the stroke leading to disability status or even death. The alarm feature that we recommend to recognize, the nickname is B fast. B is mean balancing problem. E is mean eye problem. F, that means your face problem. A, that from the arm and your leg, that means your motor power. And S, that means speech. But the simple is everything that happened to your body abruptly, please think about stroke. Okay, everything that happened to your body abruptly, okay, please think about stroke. Stroke is a time-dependent disease. It's treatable, but limited by time. If you can access the treatment paradigm as soon as possible is good. Nowadays, up to 24 hours, we can treat the stroke by many choices. Okay. The risk factor of stroke, as you know, this share risk factor of cardiovascular disease. This is artery, this is vessel disease. It's content of your aging, your genetic, diabetes, hypertension, cholesterol, triglyceride, okay, obesity, okay, smoking, alcohol, okay, and the modern risk factor that we found that associate with the stroke is sleep apnea. It's easy to test and easy to correct and easy to abandon. So sleep apnea is the important risk factor. Please concern about it in modern risk factor of stroke. Okay. And how we know? In this point, we need to separate the situation into emergency situation that patient face to stroke. We not talk about that point because leave it to hospital and emergency department to take care of you. But before the stroke happen, we can assess the risk factor that maybe we can prevent you from stroke. As we talk, the risk factor of stroke can be from your aging you cannot change, genetic you cannot change, but hypertension, blood pressure, cholesterol, triglyceride, obesity, obstructive sleep apnea, we can change. Or smoking, alcohol may be difficult to change, but we can change. And heart, we talk about the thing that we can prevent. Okay, so we recommend to you to check your blood, cholesterol, hypertension, check your blood sugar, check your lipid, and check your artery, and check your heart. In European patient, we highly recommend to check the extracranial artery because according to your genetic, is much more incident to have a plaque or the problem inside the carotid system outside your head. It's big difference from Asian population. In our Asian population, we rarely to have this inside the neck, but we have the stenosis and the plaque inside the skull. Why we recommend to check? Because if we found some problem, we can correct it before it turn to cause stroke. In modern medication, we can put the stent easy. You stay hospital one night, and you go to normal life. We can check it without any risk. And today, without any pay, we check for you after this talk. Okay, and it's much more difficult in Asian population because we cannot perform ultrasound through the brain. We use different machine we call TCD that we not bring it today because it takes a lot of time to check the artery inside your skull. Okay, but and in target population today, it may not the mandatory to check inside the brain, because if you had a problem, it start at the neck first. Okay. In the other hand, if you would like to screen your artery complete system on one exam, you can go inside the MRI machine. MRI machine nowadays no need any dye. Okay, we can use for screening your artery too. It's very rarely to use CAT scan nowadays to screening the stroke, because it's contain radiation and you need dye anyway to see your artery. It's different from MRI. And how to treat when the patient came to hospital. If it in time, we can reopen that close. Okay, we can reopen that close, but in limit window of time, very limit. So this is very important point. If we do our best to prevent, and unfortunately we had stroke, the most important thing is go to hospital immediately. Please do not observe your symptom at your house. Any hospital close to you. And the last, this is really the newest treatment from stroke nowadays, and we can do it. We call the mechanical thrombectomy. This like when you had a heart attack. The heart doctor will put some wine and remove the clot that occlude your artery. We can do the same, but very far and very much more difficult than heart procedure. And limit time is different from heart. We can remove the clot from your brain artery by the suction or by the stent removal. It's different from patient. But limit time. And this, in case who had a plaque, big plaque inside the neck, we can clean it up first. This is the prevention. It's not a treatment. It's a prevention. It's different. In emergency situation, we have only two choices to reopen your artery. The medicine that we call thrombolysis agent, RTPA, or mechanical thrombectomy that remove the clot. But for the prevention operation, we can clean for prevent next stroke. If that stroke it happened from your narrow of your carotid artery, or nowadays we prefer to put the stent much more than the operation. Not all stroke patients will disable for life nowadays. Okay, from our data, it's only 2% of stroke patients, okay, as a recurrent stroke in a 1 year. This is the most important point, that we can prevent the next stroke 98%. Okay, and more than 80% of patients live independently after treatment. Okay, this is all from me. Let's check ultrasound. If you have any question, you can ask me, please.
I have two questions. First one, I had electrocardioversion 6 weeks ago because I had an irregular heartbeat. Now the heartbeat is normal. Does that reduce my risk of stroke?
What kind of we need to know about the exact type of your arrhythmia. There's only one group of arrhythmia that increase the risk of stroke is atrial fibrillation and fluster. What kind of exact arrhythmia can you?
I can't remember what the exact type. But now my heartbeat has normal sinus rhythm.
That means your risk return to normal.
Yes. So does that reduce my risk of stroke?
Yes.
Also, I had angioplasty, and my arteries to my heart were perfect. There was no sign of any blockage or any buildup inside my arteries. Would that mean that the arteries going to my brain would be similar, or that's completely different?
Neurological deficit symptom, that means your brain still got the sufficient blood.
Okay, thank you.
But the same, we cannot give you the word that exactly the same amount.
Okay.
But sufficient.
But it gives you some idea that it's okay. Thank you very much.
Good for another week.
On your right side.
Hello, thank you for your talk, very interesting. If you have no history of cardiovascular disease, would you recommend taking a daily aspirin dose of 75 milligrams?
We still not recommend.
Still don't recommend?
In the past, we recommend in some
Yes.
But from update that medical data, we not give the aspirin for primary prevention in every patient anymore.
Okay, thank you.
Yes, you're welcome.
There's one. Yeah. Okay. Who's the one here? You.
Hi, this may be based on out-of-date information, but there was a very extensive article, very long feature in the New York Times some time ago about a doctor who had a stroke, and it was very severe. She went immediately, she could tell it was a stroke, it was very severe. She went to the hospital, and she insisted that they give her that RTPA immediately. In the US, they would normally wait to screen you first, and that takes over 4 hours. And she said that was too long for the TPA to be any good. She'd rather get the RTPA, even though there's a risk that if you have a hemorrhagic stroke, it'll kill you. So is that still the same? Does the RTPA, do you need the intervention in 4 hours? Do you guys do screening, or do you treat people within 4 hours? How does it work here?
When the patient come to hospital with suspect acute stroke, the major thing that we need to see before everything is the imaging.
Right.
That we need to exclude the hemorrhagic stroke from our treatment first.
Well, can a patient? She insisted on getting it without imaging, and the odds are, the article said 5-6. Can you as a patient insist, say, I would rather get the RTPA and risk dying than risk the stroke damage? Is there any way, or can you get it in your records? Is there any way to insist that you get RTPA? The odds are 5-6, at least this article said. The odds are 5-6 that it's a clot, not a hemorrhage.
Yes.
And this doctor said she'd rather take the bet than live with the kind of stroke damage. She was half paralyzed. She could barely talk.
Excuse me, I'm not sure that I'm not understand the question clearly.
Can you, as a patient, say, I want RTPA, I don't want to wait for the imaging, I don't want the risk of the damage?
Cannot.
In the US, you could. Okay.
This is medical mandatory.
Okay.
If you don't want to, if we cannot see inside, we not give TPA because it's very high risk medication.
Right.
It's not only the emergency stroke that RTPA that can make the people die.
Right.
The rest and the another disease that we cannot give the RTPA.
Okay.
We so scared, don't worry. We worry about this because the RTPA profile the benefit of RTPA only 33%, but it consists 7%. It's very big risk.
Okay.
7% risk. So in Thailand, if patient no image, we cannot give RTPA anyway.
Are you usually able to do the imaging within 4 hours of when someone arrives?
Yes,
Or within 4?
immediately.
Okay, so that's a problem in the U.S. In the U.S., you would not get the imaging in 4 hours. That's the problem. Okay, all right then.
Okay.
Now in Thailand, when we Thailand standard, we force to get the image within 15 minutes. Wow. Yes.
Okay.
We need to say the patient. Our KPI, our target is we would like to see the image within 15 minutes.
Okay, if I can comment, and it's not a question, it's a statement of what myself, when I had my stroke here in Thailand, 5 years, it's been 5 years or more ago. It was an ischemic stroke. But to answer your question, I was in the hospital within an hour because I live in Jomtien, so I went to Bangkok Pattaya, which is my hospital. And the first thing they did was a CT scan. It took them all of about 5 minutes to get the results. They said, yes, you have an ischemic stroke. Then they offered me the opportunity of the medicine you're talking about, the blood clot busting medicine. I said, yes, I want it. They gave me 2 doses. It was about that time about $1,500 US per dose, but in the US would have been over 2,000. So, but yes, they gave me the medicine, and then of course I was in ICU overnight. I was only in the hospital 2 or 3 days, but today the only lasting effects I have, to kind of give you my symptoms, which may help, and their BFAST is a thing to watch. You don't necessarily have all of them at once. Any of them can be an indicator. But in my particular case, I was home, I was alone, I was having my dinner, watching TV, and I suddenly realized I didn't have the use of my left arm. I lifted it up, it fell down. Then I noticed I was having a little bit of numbness on the left side of my face, so I immediately said, I think I'm having a stroke. I called my Thai partner, who was visiting close, and he came immediately. I was going to have him drive me to the hospital, but he had just gotten his driver's license, and I could see him trying to get down Sukhumvit Road, worried about me and getting me to the hospital, so I had him call an ambulance from Bangkok Pattaya, 1719. The ambulance arrived quickly, and as I said, I was within an hour, and the medicine you're talking about, the last time I checked it, the FDA in the U.S. says you need to take it within 3 hours of having a stroke. The sooner, the better. 4 hours if you meet certain conditions. I don't know if that's changed or not, but that's what it was at the time I had my stroke. But I will say this, the treatment I got at Bangkok Pattaya was quick, effective. They diagnosed it immediately. Like I said, the TC scan ruled out a hemorrhagic. It identified the ischemic stroke. And the cause of my stroke, atrial fibrillation, which I still have. But I am on medication, and as I say, that stroke was 5 years ago, over 5 years ago, and I'm still getting along. I have other problems, but not that.
Thank you for your sharing your experience. Thank you, Mr.
Yeah, it was an impressive machine outside, Doctor. Thank you very much.
Yes, thank you.
So my question is, I did have a TIA or a stroke or something 20, 30 years ago in Malaysia, so I'm not really sure what it was. But my question is that, you know, he's mentioning some people take aspirin, but I was on epaulets, Plavix, clopidogrel for 20, 30 years. About a year ago, I stopped it because, and I got back on statins because they put me on statins as well. And everybody's saying, nobody could give me a definite answer. But as far as I'm aware, Plavix or epaulets, they don't thin the blood, but they can stop you getting a stroke. Is that correct? And would you recommend that I go back on to back on these?
If you're established, if you experience stroke or TIA one time in your life, at least one time, please do not stop your blood thinner.
My problem is that in the hospital in Malaysia, the state hospital was not very good, and not convinced it was a stroke. I'd been travelling a lot in Australia. I hadn't drunk enough water. To me, I think it was dehydration, and not necessarily a stroke.
This is the classic problem that we call the aspirate diagnosis. You understand me? Every diagnosis is different sensitivity and specificity. In the MRI era, we can give the precise diagnosis, but in the past, 23 years ago, we don't know about CAT scan, see nothing. We just exclude the hemorrhagic stroke from CAT scan. And we perform diagnosis based on physical examination and history only. Can be missed. It may not real stroke or TIA as you suspect, but nobody can give you the exact precise recommendation in this problem. But if you can use APOLET 20 years without any bleeding complication, we still recommend you to resume APOLET.
So yeah, I understand with my thing there. But what about many of these people taking aspirins and things? I mean, shouldn't they be on Apolets or Plavix or something?
Aspirin and Plavix is the same purpose and the same level of recommendation of use. But the disadvantage of aspirin is your stomach irritation. It's different from APOLET or clopidogrel. It not irritate your stomach. Okay. But it's much more expensive when compared to aspirin. Aspirin you buy in the pharmacy 100 tablets 30 baht. APOLET you 40 baht. 40 baht a tablet. Okay. And some patient had a high metabolites to APOLET, cannot use. We can check it from the genetic. The APOLET not work in some group of patients, but rare.
Thank you.
Yes, welcome.
Just a couple of things. Firstly, it was a wonderful talk, and I'm really glad it was short because people want you back out there doing the tests, right? So, and thanks, Daryl. That was a wonderful sharing. And I was reminded of when you shared about things like this when we had the talk of insurance and how you need a level of insurance where you can get really quick care, right? You can't muck around. And the guy who gave a wonderful talk on insurance, he's over in Turkey at the moment. And this is an insurance specially geared around expats. We've got a couple of members who's gone on it, and they're finding it really positive. So come and give me your details, and I'll put you in touch with the guy. If you're an expat club member, he gives you a 5% rebate if you pay annually. All right. And just finally, how important is it if you are given the medication? If you're considered high risk, because a friend of mine was very high risk, Afro-American, who tend to be at higher risk of stroke, and he didn't stay on his medication, and that was not a good result for him. He had a massive stroke. So very important if you are given that medication to stay on it, right?
In patients who have the risk of stroke, we highly recommend to use the medication together with lifestyle modification to minimize the risk of stroke.
Thank you. Come back up. Oh, another one. Excellent.
Doctor, yeah. You're talking about your face drop indication when your face go down on one side. I woke up one morning, looked in the mirror, which I don't do all the time, and my face fell down. And a bit of a panic, I thought I had a stroke. And I got in touch with, because I used to work within the hospital, I got in touch with a very good senior therapist. She asked me to, and I had an ear infection. And what had happened, all the side of my face had dropped. And she, through the consultant, gave me steroids and heat treatment. And as you can see, it returned because it was done within an hour. That's important, because once them nerves die, you got a droopy side for everything. And it affected my drink. The beer kept falling out of my mouth. And one other thing, I've been taking aspirin since I was 16, 81 milligram.
All right.
I'm pretty old now. It ain't done any problem. Because you must drink a lot of water, and when I suggest don't take it at night and go to bed, move around so it doesn't settle in your duodenum. That's where the problem is, aspirin. And certainly don't take more than 300. Okay, thank you.
This is different type of face drooping. Basically, unequal face drooping can caused by two different causes. One, the stroke, and the second is the nerve that this man sharing about. This is the nerve affecting, not stroke. Don't. Yes. You should to go in to doctor to clarify this point. But if you would like to know, I share with you. But please do not judge by yourself. All right. If your face drooping, but you can close your eye properly, it's bad. It's stroke. If your face drooping and you cannot close your eye properly, it's good. If your face affect mouth only, it's not good. If affect your eye together with mouth, you can wait. But this is not official recommendation, alright? Because if the nerve affect, it affect both eye and mouth. The patient will experience same history. Doctor, when I woke up this morning and I brushed your teeth, I cannot keep the mouth, keep my water in the mouth, and the water pour this is, and cannot close the eye properly. This is from the nerve, and mostly it's from the infection of the virus. Yes, and we use steroid. What kind of nerve? The facial nerve. No, it's from your brain stem. The nerve that affect the face, your face nerve is arrived from your brain stem. The number 7 nerve that cause your face drooping and cannot close your eye properly.
I have the treatment, use steroids.
Yes, sure.
Reduce the inflammation.
Sure.
And the heat treatment to release the pressure in this small orifice there. And within 2 days, 3 days, my face should do it normal.
Excellent.
I don't suggest you wax. I suggest you get something for that. Because they can be permanent. Many times I've seen, I'm dealing with an orthopedic surgeon. He had exactly the same thing. And his face collapsed, not returned.
Basically, the prognosis of nerve inflammation by infection or virus is very good. It will return to normal, ordinary normal within 3 months. But some patients not return.
Doctor. Yeah, thanks, doctor. You're a professional, yeah? If I have big problem with my heart, Thai ladies break my heart. You can help me?
I have the same problem with you.
Mike. Oh, one more.
Here we are.
difficult when it's full.
Thank you for your presentation. You had mentioned the term lifestyle intervention. Okay, can you expand upon that a little bit? What we can do in our lives to help prevent this?
Yes, according to medical recommendation, the lifestyle that good for the prevention of stroke is exercise, dietary, weight control, okay, and smoking, alcohol, and sleep not less than 5 hours. Yes, sir.
Excuse me.
If you wake up in the middle of the night and you normally don't have headaches, but you get an intense, very intense localized pain headache, and it lasts just for a minute or two, would you recommend going to the hospital? No other symptoms.
No any symptom, just headache.
Yeah.
In the night.
Yeah, for 2 minutes. For 2 minutes, like.
2 minutes. This situation may not really, not exactly directly related with stroke, but I will answer. The headache, we can divide into easy way to group. One, without alarm feature. That means benign headache, tension, migraine, muscle, and headache with alarm feature. That recommend you to go to doctor. Night pain is one of alarm feature. This is what we call night pain headache. We recommend you to perform scan to the brain.
Thank you. Thank you very much.
Oh.
Hello. In the last time, I have often the double vision. When I sit in the computer at my home, no problem. But when I drive in car, I see a double vision. The distance starts with 10 meters. That person I see just double. But in the computer, in low distance, I have no problems. What has that to do with stroke?
Close your eye first.
Then it's a single. I had just 3 visits at eye doctors, so everything is monofocal, and double is double vision. When I open both.
I mean, after you close your one eye, it's still double.
Okay, no.
If how long you had this?
I don't know it. Maybe 10 years coming from cataract. But now it's.
I mean you stay with double vision for 10 years.
I don't know it. I don't know it. I didn't know when it started. But it's, how to say, Lamkan. Why? It's so, 75% is double vision, and that part is okay. That means I look so and see everything clear. But when I look so, I see double, only this part I see clear. Oh, sorry.
But you check your eye, everything normal, right?
Doctor told me he has to do here.
Yes.
To check from 1% to 100% security cost only 50,000 baht. And so I'm trying to take a Fresnel lens or to try first other things.
Basically, this is interest problem and complicated problem because this is what we call binocular diplopia. That basically is not arise from the eye problem, it's from the brain problem. Because this is the alignment abnormal. This is abnormal of your gaze. That means when you order to move your eye, it's not same angle move. It can cause by your many things inside the brain, in the lesion that in the area that control your eye movement. Okay.
Yeah.
Including stroke. But here is not classical. It's not classical history. You need to check your eye and check your eye movement, and you need to see your MRI every day to see what happened. But this is interesting complex.
Please come on stage so we can give you a small thank you of our appreciation, Dr. Natagan. Actually, you're the first speaker who's wandered around the audience when you're answering questions. It actually worked really well. It's cool. So
The author run.
Yeah, run. Run, jump, skip, hop. We have a small token of our deep appreciation for you coming here. I feel we should give a certificate of appreciation for the machine. Oh my God.
Thank you.
Thank you, Doctor. That was fantastic. Thank you. And of course, the real highlight of the morning, the lucky number prize. What is the prize?
The ultrasound dropper carotid artery, the one that you just did this morning,
Yeah.
is more expensive, so it takes longer. Okay, so the lucky draw prize today will be the ultrasound carotid arteries, the one that you just did today. But this morning is just the initial test, but the proper one will take about half an hour. So this we will give 5 for complimentary today.
I think we can trust the doctor not to do a sleight of hand or a stroke of hand. Okay. What do we got? We got 1, 2. You want to read out the numbers? Come up on stage. Yeah. You're off the hook.
Okay, and the lucky winners are, the first one is number 23. 23, okay.
Stay there for now.
So that we will give it to you later. Okay, and the second one is number 20. 20, yes. And the third one is lucky number 29. 29, okay. And the fourth one is number 17. 17, huh? Is,
You don't put your hand up, we'll redraw.
we will draw again.
17. 1, 7.
Okay. The next one is number 21. 21, okay. So shall we draw another one just to replace number 17?
Number 2, right?
He's looking for it.
Tam.
Oh,
It's
one, that means 2, right?
Number 11.
number 11. Okay, thank
Where's
you.
number 11?
Over there, gentleman over there. Okay.
And thanks, of course, to the doctor for coming and all the staff for coming. The Bangkok Potato Hospital, just a great friend of the club. Thank you so much. It's always a great pleasure to have you here. And we have them actually back fairly soon, actually. So check your emails. If you're not on the emailing list, you're crazy. Go to the website, get on the emailing list, okay? We do have them back in about a month. Now, next week,